just to introduce myself to those who I haven't yet there. I'm John McDonald. I'm the chair of NGH and also veterans, and also overseeing this collaborative across the two. So it's really good to be here. I've been around this in a few things, and I've met lots of people. And you feel that, and it's really good some of the stuff. I've seen a bit more than that. But thank you very much. We've had a number of apologies for always doing at this time of year. So we've had apologies from Andre, Annette, Richard, Stuart, and also Naran, who's not well behind me.
She had one late on from CTO here as well, John. She's always on the link. Yeah, thanks.
And we're going to be welcoming a number of people. We'll do that on the agenda. Any comments? Sorry, any declarations of interest people want to declare? I should probably declare I'm also chair of University Hospital Leicester. So that ought to be a collaborative thing. I'll try and avoid any conflicts in that relationship. So thank you for that. That's all I'm worried in terms of introduction. I think we've got a really interesting presentation, exciting presentation coming up. Helped hugely by the fact that the day ago I met some of the consultants who had a piece of cake which is even better. So, can I have over to you?
Thank you, Chair, and thanks to the board for giving us an opportunity to share with everyone our journey of robotic assisted services over 1 year. So we have today Mr. Tanabalam Chandran, who is a robotic lead consultant urologist. We have Alice Knight, who is a urology clinical nurse specialist. We have Charlotte Boyce, who is an operational improvement lead. Liz Summers, who is a cancer lead, and Satyanarayan, who is a robotic surgical care practitioner. Having said that, this has been a huge team effort, and we would like to present experience of the patients in their own words, including some slides on the benefit realization, as well as most important is our next steps and where we want to go. So I will stop there and hand it over to Liz to kickstart the presentation. Thank you.
Good morning, ladies and gentlemen. It's a pleasure to be here. And I'd like to say straight away that how proud we are as a team and as an organisation to be able to offer robotic surgery for our patients, particularly because it's improved their care and experience. I think one of the most important things that you can do is listen to your patients, listen to what they're telling you. And I want to share with you this morning, if you have the next slide, please, I want to introduce you to Phil. Now, Phil underwent surgery at a tertiary centre, and while his care was very good, and I need to emphasise that his care was very good, there are some challenges about having to go to another hospital for surgery. And for Phil particularly, travelling up and down the M1, if you've ever had to do that, can be quite challenging. He found quite traumatic, particularly after he had surgery. The journey home, he felt it was very painful, and it was very difficult for him. And this was before we had the robot here. So let's just hear from Phil about what the experience was like. Thank you.
Next slide, please. So what is robotic surgery? So robotic surgery is a form of minimally invasive surgery. And there's sort of three perceived benefits of robotic surgery. The first thing is the greater range of movement, dexterity that is available to the surgeon. Robotic instruments are able to mimic sort of the surgeon's hands without force of 7 degrees of freedom. The second point, well, benefits of robotic surgery, is greater vision. The console allows us to see in HD, the high definition 3D images at 10 times magnification, which enables us to see very tiny structures at greater clarity. And the third one is ergonomics. So this is for the surgeon. We're sitting down at the console, able to operate complex operations, but in the comfort and not having the fatigue that could be associated with traditional forms of laparoscopic or minimally invasive surgery. Next slide, please. So the benefits are threefold. It's the base benefits to the patients, benefits to the staff, and also benefits to the groups and organisations. So with regards to the benefits to the patients, the points that I alluded to in the previous slide, those are three factors of greater dexterity, greater vision, greater ergonomics for the surgeon, means this all translates to better patient outcomes. If we can see things better, in operate in tighter spaces with greater manipulation of the instruments, that all translates to better patient outcomes. This is proven in multiple studies with regards to robotic surgery. It enables us to also allow to give patients the ability to treat the patients locally. And so, as we just heard from Phil, these patients had to travel out of the county in order to receive robotic surgical treatment for their condition. Now, we can now treat patients locally, and the patients are now to meet their whole team in the whole team, which is local, as opposed to meeting different members of the teams, different hospitals, different organisations. With regards to staff benefits, again, I've mentioned it, it's for the surgeons, there's improved ergonomics with regards to decreased operator fatigue, and also increased training opportunities with regards to where the actual where we can deliver the actual opportunity to for the surgeons. Also attracts high quality clinical staff and a high caliber of staff, and I'll talk about this a bit further on. As a group, we want to maintain our status at the cancer centre, and also our aspirations going forward to develop into a cancer centre of excellence. And we want to develop our robotic surgical capacity in order to, in the future, or to develop into a potentially a robotic hub and build a benchmark model for the future of this robotic surgery in the region. So I'll now pass on to my colleague Charlotte.
Next slide, please. So I'm going to talk to you about the implementation journey that NGH has been on. So given the benefits that Tanner has just outlined, we just prepared a business case, and this was submitted and approved by, this was approved, was supported by NHS England, and we were able to have the finances to pursue with this in January 2022. We then implemented in March 2022, just 8 weeks later. Since then, we've successfully introduced robotic assisted surgery across 4 surgical specialties: urology, colorectal, head and neck, and gynaecology, for the treatment of cancer patients. As you can see in the top graph, we've had excellent utilisation of our system compared to the national average. So the dark blue line is the number of patients we've treated per quarter. And as you can see, over time, this has increased. Coming up to this year, quarter 2 of this year is the last data point on that graph. And that shows that we've treated 68 patients in that quarter, which is above national average of 62. So really, really good, excellent utilisation of the system. So then moving to the graph at the bottom, this is us reflecting upon where we wanted to be when we put the business case in. So the top line, the light blue, that was the plan we expected, the number of patients that we wanted to treat per month. And the pink line underneath it is our actual activity. So we're really pleased that we have been able to, we're slightly underneath plan, but we are very close to where we wanted to be in terms of the number of patients we wanted to treat. We've also been able to support other hospitals outside of region that have been struggling with their demand outweighing the capacity. and we've been supporting training for surgeons from other organisations. And bringing us right up to date, as of this month, we've treated our 250th patient, and it's been a really, really successful journey so far. Next slide, please. Now I'm going to talk to you about 4 key patient benefits that we've outlined when we reflected upon the service. The first one is a reduction in waiting times for prostatectomy patients. So one of the key issues that we outlined in our business case was that we really wanted to bring down the waiting time for our patients. So the national average for the treatment of patients is 31 days from the moment a decision has been made to proceed with surgery. And that's in accordance with the National Cancer Waiting Time Standards. So prior to implementing robotic surgery in Northampton, Northamptonshire patients were waiting on average 135 days for their treatment. This is way in excess of where we'd like to be. Since we've been able to implement robotic assisted surgery in Northampton General, we've really significantly reduced this. And then the top graph here shows over time from when we started in March 2022 up until May of this year, and you can see how our waiting time has come down, and it's actually around, we are achieving our 31-day target. The next slide at the bottom is just to tie into a reduction in length of stay for patients. So this is about prostatectomy patients, so prostate cancer. And we just wanted to really celebrate that we've only had this technology for a year, and when we are below average in terms of our performance is better in terms of when we compare our length of stay nationally, we are better than the national average, which is really something to celebrate. Next slide, please. So thirdly, we want to talk about the reduction in surgery converted to open for colorectal patients that have had robotic surgery. So of the 56 procedures that we have completed so far, 0% have converted to open surgery. To compare, we did a review of 72 equivalent laparoscopic procedures from 2021 to 2023, and this has shown that 14% of procedures converted to open procedures on average. This is important for patients as conversion to open surgery is more invasive, increases the risk of complications, and there are poorer outcomes for patients post-operatively. Lastly, we really wanted to consider the environmental impact of patients being able to access this treatment closer to home. From a review of 70 patients, the average distance travelled to Northampton was 11 miles compared to 37 miles at a previous provider. The total mileage saved for these patients for visits for their pre-op appointment and their treatment averaged 52 miles per return journey. This equates to a total carbon saving of 1,747 kilograms of CO2 for this group of patients alone. Now we're moving to the next slide.
So I just wanted to elaborate on some of the benefits related to our staff, which I alluded to earlier. So with the introduction to robotic assisted surgery here at Northampton, we were able to increase alternative surgeons into the post, and also we're able to then develop our own existing teams in order to actually facilitate this robotic service. So we managed to develop clinical pathways with regards to clinical nurse specialists to allow the whole patient experience, the whole patient journey to be condensed and also enhanced to allow them to have the full treatment locally from the day of diagnosis right through to the treatment and through to the aftercare as well. We're also the first hospital in the whole region to manage to recruit a robotic surgical care practitioner, Sasha, who's sitting here today. And we're very privileged to have him working here with us, and he's enrolled in the university as well to do a 2 years master's program in surgical care practice. And so the enrollment of this role essentially allows us to really progress our robotic program, and also allows us to then develop and train fellows with regards to robotic surgery in the future, opens the doors to potentially developing fellowships as well. We also develop new roles with diagnostics. So in neurology, we have nurses with nurse practitioner roles where they are doing our diagnostic biopsy procedures, and also cystoscopy procedures as well, which allows, again, greater flexibility within the workforce. And also, the key thing as well is research and allowing us to collaborate in national trials. Now, speaking as a urologist, we are the highest recruiter in the whole region for one of our prostate cancer active surveillance trials. We've got higher recruitments than large teaching hospital institutions. We've also been invited to participate in 2 national trials, which may significantly influence the prostate cancer management in the future. So one being one trial where we're the only one of 2 centres in the whole country that have been invited to participate in the diagnostic part of prostate cancer. And the second trial is a large national trial. Again, we're one of the only handful of centres in the UK that have been approved to participate in this trial, which may impact the actual future management of surgery in prostate cancer. So very exciting sort of developments happening in the clinical trials front. So in summary, so this is all helped by the equipment that we've got. So there's a large investment, and Northampton was really very good in actually not only just purchasing the robots. We've got the latest generation intuitive robots here, which allows us to do this cutting edge surgery. We've also invested in further equipment and peripheries. So we've invested in a tilt table. Now, this is an operating table that allows us to have full integration with the robotic system to allow us to move the table whilst the robot is docked with the patient. This allows us greater flexibility and freedom during surgery. We've also invested in an air seal device. Now, an air seal device allows us to perform the operations to deliver the gas into the patient in order to perform a minimally invasive surgery. This delivers it in a more secure way, allows us to perform these complex surgeries. And we've also invested in an ultrasound probe. Now this is a robotic probe that allows us to perform very complex kidney surgeries and further surgeries in the future, where we can precisely delineate these tumours and actually to get the best patient outcome. We've now trained, let's say, 6 fully trained robotic surgeons here over the course of the last 12 months. And that is across a range of 4 specialities. And we've trained over 10 theatre staff as well to develop a robotics surgical programme. As mentioned, we've recruited a surgical care practitioner, and we've done the first robotic workshop as well to train in colorectal for the actual colorectal trainees across the region. Just over a year, we've performed over 250 operations. And this is something to really celebrate. With all the scrutiny for the operations, we've looked at our results. We've got excellent results across the specialities with minimal complications. And we maintain a good quality. We have bi-weekly robotic-assisted surgical committee steering group meetings, which I chair, and we've also been approved by NHS England with regards to specialist commissioning, whereby we are an approved centre to deliver robotic-assisted prostatectomy service. Okay, next slide, please. What's your back to this?
I want to share this slide with you because all of these patients here are just a few who had robotic surgery at NGH. They have all kindly shared their stories with us, for which I am immensely grateful. Each of their stories are unique, but all emphasise the enormous benefits to their care and their experience about being able to have robotic surgery at NGH. In a minute, we're going to listen to their stories because I think the most important voice here is the patient, obviously. But before I do that, I just want to thank Mr. Namadi for all the work he's done in enabling us to have robotic surgery at NGH, the fantastic team that are here, and also all those that are not here today that are giving their heart and soul into making this happen for our patients. And we should be so proud of each and every one of them. But let's hear from our patient voice. this is what it's all about. Thank you.
That's, so we're sort of quite proud that actually this was again one of the Marnie's brainchild, this one. So when the robot was introduced last year, to raise awareness in the community, with the local primary schools, so 3 local primary schools were invited to not only draw pictures but also to name the robot, sort of trying to get big awareness around it. Very proud to say the winning names by Class 3B in the Dustin Primary School, and they named it Stitch. So our robot is Stitch, and that's now proudly displayed outside the robotic theatre here at the Northampton. So we've got a name for our robot here, some of our pictures to say we had hundreds of entries from the local primary schools, and they're all excellent and series of stuff. That's just a few, but it's been it was a very good process, and we're very proud to actually have a name for our robots here. Okay, next slide, please. So you may be asking, what's the next steps? We've now successfully implemented the first year of robotic surgery here at Northampton. 4 specialities, over 250 procedures performed. That is directly helping patients across our region. So we want to expand the service, not only with regards to the number of surgeries you can perform, also the amount of people we can reach, and also expansion of our workforce as well. We've now got the opportunity now to really become sort of the leading sort of robotic hub in the region. And by doing this, we will then attract not only more surgeons, but also develop more allied health professionals to enhance our workforce in order to become sort of the leading centre if you want to have robotic surgery. Now, by doing this, we'll also increase our research profile. As I mentioned earlier, for the urology side, we're part of 2 groundbreaking research trials, which may pave the way for future sort of prostate cancer management and treatment. And with development of the robotic surgical program, we'll have more research opportunities. And we can enhance our collaboration. As mentioned, as I say, we're already providing mutual aid to other hospitals in the region. We're also providing training to other surgeons in the region, and want to help to enhance this collaboration and mutual aid in the future, and to develop these pathways. So all of these aspects allow us then to deliver the best patient care. It's what this is all down to. It's all down to the patients, and what we want to deliver the best service. And robotic surgery is part of that ambition. And that's what I want us to drive towards. Okay, next one. Right, so this is a celebration. I mean, it's something we should be proud of. We've developed a great and successful robotic surgical program, and we've got a day which we planned for August the 17th here in Northampton. I want to urge all of you guys here and in the public. This is open to the public. Thereby you can actually chance to meet the surgeons, the clinical team, the health professionals that are involved with the whole surgical program, and also get a chance to play with the robot. So we've got the same robot that we use in theatre. It's the Vinci XI robot coming, whereby we can the public and can use this robot. And we've also invited to schools as well. So we've had releases out prior to the holidays to local schools, to invite the schools to come to school children to come here to the school and potentially inspire the next generation of potential robotic surgeons in the future. Maybe hopefully urologists like me, but I'll be hoping. But I'd like to just to highlight our flyer here. There is a QR code on this, and so you can register and get some more information following that link there. But please urge everyone to come and celebrate with us the 1 year of robotic surgery here in Northampton on the 17th. Thank you.
Thank you very much. It's a fantastic story. Any comments, observations?
Thank you, John. Thank you so much to the whole team. I think we already had an opportunity to hear from you when the robot was just introduced to the hospital. So fantastic to see you back in a year's time. It really feels like your department is hospital future. But we are multidisciplinary hospital. So what other departments should aim for to really match your level of development and your level of technology? So any ideas? What should we as the board promote for our hospital next, so that other departments become as you future-proof departments?
Well, that's an excellent question. I say it. Well, this is the whole team effort. The robotic surgery is just a part of the surgical sort of arm of it, sort of tool that we use to give access to best sort of treatment for our patients. And yeah, and the expansion of the robotic program will allow other specialities and a whole more range of conditions to be treated. So for that part of things, so how we can, and hopefully we can act as an inspiration to other departments to, as I say, to reach those excellent standards. As I say, nothing's future-proof, but I say, with regards to how we can allow the other departments to progress, I think that everyone's doing their utmost, they're doing a great job, and I might place to diplomatically hand this over to
I think the key is to inspire the departments to get onto the new technology, and which has already happened. I can give you 3 examples. One, we are one of the 6 hospital sites who are piloting the NHS England funded AI in breast screening. The second is we are also our lung team is looking at a robotic arm for precise endoscopy as part of the trial. So that's something which is going on. And third thing, I think Palmer's team is looking at using robots in the hospital as part of a month trial for portering. So I think what I'm trying to say is that when you have a technology and innovation, it rubs into people. These are the 3 examples.
Thank you, Chair, and thank you, team. A fantastic presentation, which kind of just speaks for itself. Hemant invited me to attend an operation in your theatre, and so I saw the robot in action, and I felt very privileged. And I know you're a fantastic team, but I'd just like to make 2 comments. One is that we're very, very lucky to have such a fantastic leader in our medical director. So many hospitals have surgical robots. And many of them, some of them, probably some's more accurate, have dust on them. Ours doesn't, obviously. So I think we should commend the leadership of our medical director as well as the team. So that's my first point. And the second thing is that we had a benefits realisation paper that came to one of our quality subgroups, which they gave substantial assurance to, and that was reported through the quality committee. So again, huge commendation to the team.
If I make 2 points, well, one's a question, well, 2 questions. So the first one is, you talked about expansion and your ambitions there, which are clearly significant. And I'm just wondering whether there's been any modelling done that might help us to understand the possibilities there and how far you think we might be able to go. You talked about 60 or so procedures in the last quarter. So what do you think is the opportunity? And my second question is around workforce. So clearly there's been a lot of positive impacts on workforce development opportunities, training opportunities, not just for medical colleagues here. And I'm wondering whether or not you've measured anything yet in terms of the impact of that in terms of perhaps reduction of vacancy, reduction of turnover, or improvements in staff experience and how your staff are feeling about coming to work.
I will answer that. So in terms of workforce modelling, we've already done and it was part of a benefit realization paper where 2 difficult to recruit consultant posts which were filled by agency have been replaced with substantive posts in the gap of 1 year. Second, we have done is 3 clinical nurse specialists in urology has been substantively appointed. And in terms of developing the workforce, there have been allied health professionals who have been upskilled, and we have Satya has been going to the university for his master's. So that's point 1. Point 2, we haven't done any pulse survey specifically around robot for looking at well-being, but what we can see that the team are really enthused on the shop floor. And final point, your first question about expansion, yes, we have done modeling in terms of the next 6 months to 1 year, and Palmer will talk more about it because they have been heavily involved along the financial team about for future modeling. Because at the end of it, we need to make sure that it is cost effective as well. This is just not, because it's an expensive tool, and we need to make sure that the modeling does. And our case benefit realization paper and what Charlotte presented in a nutshell is a lot behind it in terms of what we projected to do and what we have achieved. And there's a further modeling on these papers.
So what would the benefits realisation was on the staff? The reduction in agency spend and more of our own. That was achieved. However, the spend is still the same because actually the demand there. So we've gone to Saturday, Sunday working, and actually some days they're working to the evenings. So whilst the cost has gone up in relative terms, actually the activity has gone up to match that. So it's a huge move forward. What Hemant's alluding to is the region have asked us to take on more mutual aid for those across the Midlands. So Worcester, particularly one of the patients, but also Wolverhampton, patients got a long wait. So they've the centre have now given us extra funding to install a second robot for 6 months. That will be starting in August at some point, still to be confirmed the exact date. And that will allow us to then reduce the backlog across the Midlands because we've been the one site that seems to be able to achieve. And what I can't stress how good these guys are is keeping that wait for your prostate patients so low, whilst also giving time for co-reps and then guiding patients on that, which is just normally in a trust, it would just be urological and hit that with growth. These guys are incredibly well to do that. And obviously we're looking across the schedule as well, helping them support training through this. And obviously the board will be rightly concerned what happens to patients who are moving around in the sector. So they're also funding from the centre ability for us to move to the independent sector or patients. So we're opening up a theatre and independent sector with our surgeons looking after our patients, as well as moving a lot of staircase, which we can move across from other specialties. And lastly, then in the next month or two, we should get a Vanguard theatre on site to then bring our independent sector capacity back in, so we're not spending that extra on there. But that was all funded externally, that wasn't through the time going forward. But it's all been mapped across, and when we are meeting the ICB together this Monday to make sure the assurance there on our patients, the quality, all about making sure that our people in Northamptonshire don't get a raw deal by us helping them, which we want. And you can see that we're already helping Worcester, Leicester, as well. So all our times are still at, I think it was 22 days of treatment.
Just a couple of things. You know what? I'm incredibly proud of all 6 of you there and your teams, but you have made this happen, and to not just make it happen, but then to start beating, the norm is incredible. And I think the other thing is looking longer term on this one. The more people you treat via this method and reduce their length of stay here, then the more time and beds we've got to spend on more complicated surgery, and it just makes sense. And I know it's stressful because been talking to some of you this week, but actually it's absolutely the way forward, and you guys are in front of it. And just want to say thank you, really appreciate it.
And actually, Rachel's probably just made my point, actually. I've sat in a number, over the last 6 weeks or so, sat in a number of board and committee meetings, and the way it is, every single meeting where we've got together as boards and committees, at some point the robot has come into the discussions. And Liz, you started off by saying how proud we should be. Everyone's so proud of what you've done and what you're doing, and that pride comes through in all of the discussions that I've heard and taken part in. And I would also echo what James said, without singling out one person, without the vision and determination of our medical director, we probably wouldn't have been around. So.
You're going to make a point on the robot, on the slide, post-robot.
I just wanted to make a point is we have been trying since 2019, but Heidi is not here as chief executive, and when she arrived, this made it happen, and along with the executive. So it's just we have been trying as a team since 2019, but we need to acknowledge our role in getting the national funding, which was impossible till she arrived here. So we need to acknowledge in our absence. Okay.
So Mother, they were just talking about pride and probably getting the biggest daggers from across the room. But who's going to come up with the chief exec's report? And but whilst she's in the room, Dame Ruth May visited us last week and actually gave out one of her gold awards, which she does not give out very often in summers, hiding already with her hair down. Which awards with all service for all her work across life. Just a huge congratulations. We're really proud to have you as part of the team. Everything you do for all patients is incredible.
I would second that. Seriously, I've never met anyone who is so motivated in terms of patient care. Fantastic.
Just to echo the comment, it's really is fantastic to see this in the drive, determination, having some success, and so I just like to make a look forward to the people are doing, but thank you very much. It's a fantastic journey. It is still carrying on the journey, and we look to support that as much as we can. Thank you very much indeed for a couple of days, but more importantly for the work you put in over the last year or two, being this really out. Thank you very much.
Thank you.
Okay, guys.
Just a few very brief words to briefing about my. So I'm really pleased to be here. Some of that today because which is very important. I really as well to others. Thank you very much for that. As I said, it's really focus on access to trust houses, leading the regions, this fundraise and working this as well. So, having said that, those are the challenges. It's really important to celebrate the success as well. So, trying to grab some of the huge challenges, not just that for those people on the NHS in the next year, getting that balance right is going to be really important to encourage workforce and to let them know support as well, because the workforce here it's not an easy time of COVID and trying to cover stocks and follow. These sorts of that really is good. Having said that, there's a really big opportunity, I think, for trust and deep wider collaboration and we coming back together. Just one, the Health Federation put out a report earlier this week looking at the future health of the population across the world. It means quite depressing. We're going to see a 20 to 25% increase in the number of proportion of the elderly people that have long-term disease over the next few years. If you add to that the fact that the number of older people is also, I think there really is a role for us to play, not just in the treatment, but in some of the preventions and the wider things. And I think that that's quite a different role for the hospital, but I think it's really important. And we think through some of those. So there are obviously opportunities in the trust, but I think there's some wider opportunities for us in terms of what we're going to shift. It's state of intent, not necessarily seeing that translated to actually think of the health service not just as a treatment service, but as a prevention and health service as well. And people around here have the expertise and skills that play a huge role in that. So I think that's just one example of where we as a hospital community, and I was thinking of all the hospitals need to think very different about what contribution they can make to their children. So I think there are some really exciting opportunities, really big challenges. But where you are now, our family has taken so much in place. It's really good. I'm delighted to be joining key with that. Let's go to that place because there's lots of trust and share there. So that's what I want to say. Happy to
Thank you. Yeah. So I would just obviously send her apologies. She'd first like to say an enormous thank you to Rachel and everything in the last few months as the chair, as a handover. So thank you very much for steering us through, and a huge welcome to John to the trust. And we look forward to collaborating. So just some of the highlights from her point of view, the pathway to excellence was an enormous success for NGH. We were the first one in the country to firstly get the pathway to excellence and then to re-establish ourselves on there as an enormous success. 60% of nurses needed survey, we did 83% with 1,089 nurses. Every 50% agreement rate on every question was required, we got 96%. And 75%, out of 28 questions, we needed 75% strongly agree on those. All were above 75%, with 11 over 95%. So enormous success across the board, all our nurses. Enormous thank you to Maria and particularly Debbie, our outgoing nursing director, in terms of the amount of effort and her team have put into making sure this happens. Well, I've talked about Dame Ruth May's visit, so announced that to all our nurses internally, and she also gave 2 silver awards to 2 incredibly important nurses, and our gold award we talked about. I'll cover operational performance, and I'll come to it, otherwise I'll be here all day. We talked about the cancer and the robotic 250th case and the future around regional hub supporting them. Industrial action is just a huge thank you to all our staff who have supported our doctors' right to strike, be that junior doctors and consultants, particularly how they have dealt with those strikes, in particular the last 2 weeks, with junior doctors backing onto consultants. I think the trust's got to be hugely commended in terms of how they've kept safe and effective care going throughout for all our patients. And indeed, we actually had all one at one point during that entire time. Our partnership working is something we're really looking forward to. We've got the East Midlands Acute Provider Collaborative. We've now got UHN and UHL collaborating, and we continue to work with the ICS across the board. Not just in terms of operational and clinical, we also have our Tracy Robson, our Director of HR, is the EDI lead across the system. An enormous thank you to her. She continues to do it across the system on behalf of us. And lastly, just a note on that clinical side, the trauma orthopaedic department have got the National Joint Registry Award, which is no small feat, just simply to get the amount of data in. But also on the back of that, it shows that we are doing the right orders, the right time, looking after patients with the right outcomes. And it's a huge kudos to the team for managing to get that in, but also to demonstrate the level of care they are giving to all of our patients, be that our electives, elective orthopedic wards, or our fractional clinic feelings, or the trauma side. So I think everyone across the board really focused on quality in the last couple of months. I think that really shows the process showing in the outcomes, which we'll go through some of before.
Thank you, and thank you, Palmer, for a very comprehensive Chief Executive report. It tells the very positive story of Northampton General Hospital, which is great. In Heidi's absence, she asked me to add to dispatches that David Moore, who was a non-executive director here until last November, has been given an honorary Doctor of Laws in July for his support to us, the university. So given that he's so recently been with us, she was keen that we added it and congratulated him at the same time.
Yeah, certainly do that. Okay, now, unfortunately, I've got much too efficient so this book I won't take catch up time. I'm not improving the minutes and minus tonight, so I need to go back to that. Please. So any comments on that? I see the last one. Thank you. I'll take those back to record. And the 2 open actions here. The first is about having non-execs on the ICB committees. I've talked about that with Rachel. We're currently looking at the number of eyes lens, and we'll look at that. But I think there's also some discussion we had with the ICB about what the purpose and value of the setup. And I really think that there is some value in participating in this business. So over the next couple of months, we're creation already talking about some of the lead on the vacancy coming up. So that and we're obviously about that later. We want to move on that very quickly for the capability. We said that good. And but also we have some discussion with later this meeting will take the time and very busy so much about it. Make sure that's the case. Okay. So that's on that side. And probably living managers, strategic objectives.
So there's been a number of conversations with exec leads for each of the different priorities, and we've been working through what the plans look like. We took the opportunity to take the plans and the discussion on the strategic objectives to the divisional away day in July to make sure that those plans are really rooted in NGH as well as the things that are taking place across the group. So that's a slight delay from where we were hoping to be, but should go to board committees in August.
Thank you. Thanks, thank you. Can we move then on to the board committee chairs reports? The committee chairs reports. Use for the call names.
Yes, don't worry.
That's great. I'll leave it to you.
So we start with the group clinical quality safety and performance committee. So Jill.
Thank you. So in Andre's absence, I will report on the last two committees. Unfortunately, we didn't have the opportunity to see the IGR report because it wasn't ready for either committee. But our convener always asks at the beginning if there's any urgent business or anything that we need to know about that isn't in the papers. And so you will see at the beginning that there were a couple of issues that we spoke about, and we got substantial assurance in relation to them. We also had an update on the organisational development work in the oncology service at NGH, and it was a very thorough paper. We were very pleased to receive it and felt that it merited reasonable assurance because of the activity, and looked forward to having an update in line with our plan that supports the committee. We have, as colleagues know, a number of subcommittees that report into the Quality Committee, and we now have a finite number between both Kettering and Northampton. We can't report on all the papers that come to those committees, whether they have reasonable, limited or substantial assurance. So we usually highlight to the board the areas where there has been limited assurance. Overall, we felt there was reasonable assurance because there is a spread across the different committees. This is working really well in my opinion, because it's a fairly new initiative, and it's not we didn't have such formal reporting when we had single committees, so we find it really helpful. In terms of the limited assurance for NGH, in June we heard about, I'll just check my notes. We heard about the workforce in ED, although we've been updated since then to recognise that that's an improving picture. Also, some administrative and clinical space in the medical division, still work in progress. And in July, and you'll see this echoed elsewhere, some issues in relation to digital access for maternity services. So we have a maternity hub called Far Cotton, which still has no internet access. There are mitigations because the team are using dongles, but it doesn't look as though that will be resolved until the end of the year. But we are, of course, working very closely with the digital team to see if there's any resolution on that. So that's the subcommittees. We received the Director of Nursing reports, and at NGH, unfortunately, we haven't been doing quite as well as we would like to in relation to Clostridium difficile. And when we do a root cause analysis of every single case, it is always where there are lapses of care, antibiotic prescribing. So there's a lot of work going on in relation to antibiotic stewardship, and we're just beginning to see the numbers fall. So we will continue to keep an eye on that. Maternity safety, again, you will know digital issues on a broad front, and our digital group director is working very closely with us, and also coming to the next quality committee or one of her team to talk about the issues which still require resolution. Finally, in June, we had a paper on breast service collaboration. We noted that the work is in progress and there is an action plan. There are some real workforce issues here. And we felt that because of the workforce issues particularly, we had only limited assurance, but we are having an update in September, so you'll be hearing some more about that. So in terms of the July committee, again, we had upward reporting from all our subgroups with a range of assurance. continue to have limited assurance in relation to maternity services access to Wi-Fi, but I've already noted the mitigations in place. Also, very helpfully, we heard about the change in anti-embolism stockings at KGH, which prompted us to have another look at what was happening in this hospital. So that was helpful, but overall, again, reasonable assurance. There is a paper on the agenda in relation to the committee effectiveness. The reason this only got reasonable assurance in this meeting was because there wasn't an entire consensus about the committee proceeding as a joint committee. It was supported by the 5 non-executive directors that attended the meeting and KGH executive colleagues, but NGH colleagues were more ambivalent, so we felt we couldn't give it substantial assurance, even though it's an excellent paper, but at this point we gave it reasonable assurance. You can see the ED paper, which we always congratulate Palmer on, got substantial assurance, and we've already spoken about the pathway to excellent reaccreditation. We had a new issue raised with us around obstetric workforce in maternity services, including a fetal medicine vacancy. Now, this is something that it is apparent across the country. Our KGH colleagues actually buy that service in from Leicester. We have been out to advert and not been able to recruit. So again, very much work in progress. So there is reasonable and limited assurance in relation to those matters. Thank you.
Okay. Hemant? Anything to add? Thank you. Audit.
Next one, just before we move on, are there any comments on that questions on the quality?
Thank you. Thank you very much for the hard and the joint work with KGH on ensuring the high quality of our services. I appreciate that IGR was not available at the time of committee meeting. It was the same case for people committee, but now it's part of the board paper. Listening and reading the quality committee report were primarily reasonable, substantial assurance, and there are very small pockets of limited assurance. When I'm looking at the summary table, which summarizes KPIs for the quality committee, it's pages 25 and 26 out of 79 IGR pages. The assurance level, which informatics give us, or data gives us, either not consistently anticipated to meet target or consistently anticipated to not meet the target. So it's very difficult for me as non-clinician to triangulate this with the quality committee report. And I know I sound like a broken disc or broken whatever. Thank you. But number of medical medication errors of 145 for the period, for the report period, which I think it's May, because IGR is dated 1st of June. It looks so much bigger compared to KGH, and serious or moderate harm incidents, again, so much bigger at NGH compared to KGH. So the question for me to understand why the informatics trade our quality in such, I would say, disturbing way.
Chairman, I respond first and then hand over to Hemant. I'm also a broken record on the fact that much of the information in the IGR, some of it, is quite misleading. And Hemant will explain medication areas, which he has explained before. The number of serious incidents, there isn't a standard, Elena. In fact, you should be proud that we have serious incidents and we declare them. You'd be quite worried about a hospital that didn't have a number of serious incidents. And comparing across two trusts is quite difficult. and Natasha can support this, but the IGR is still very much work in progress. Sometimes the data, finance and performance is very clear, but sometimes the quality data is not acceptable on a piece of paper and a graph. That's why we have papers to the quality committee. We have a discussion because the numbers are not terribly helpful. I'll hand over to Amanda in terms of medication errors.
It's really very important that something comes to the public domain, which without accompanying report is kind of could be misread.
So, Chair, I agree, and I have suggested that we put a watermark on it to say work in progress, or we receive it in private, because I think where we have misleading information, there are a number of sections of misleading information, which I won't wax lyrical about now. It's kind of unhelpful.
And I think this.
I think you raise a really good point. We do need to look at some of this, because I think it's right. And this is an issue in lots of different places, but we do need to get, but also 79 pages that have actually way through. So I know there's discussion going on here, so I think first we've done it, I think you guys need to look about where we got to it. We need to continue to carry on refining that, and probably need to both step really greater to learn how to go and qualify. Seems to be quite difficult for the public to understand that.
Yes.
And I think we need to think about that. So it's really good for the players. I think that after this, the job, keep that place, the lowest discussion.
I think, I mean, we have discussed multiple times on the IGR, but specifically on your query of medication errors, it was, we should consider 3 points when you compare catering versus us. First is we do not have an EPMA, if there is an EPMA there, which has a forcing function to prevent our errors. The second question is we have a point is we have a ward-based pharmacist. So we have a very robust process on the ward, where the ward-based pharmacists detect errors which are on paper-based, but that does not mean that gets extrapolated into actual potential harm, because there's all detection. And we have always said in the quality committee that EPMA is as a forcing function, and once we get it, this will come down. On the medication, on the moderate harms, this is all in the public domain, because it is all moderate and above harms gets recording onto the STIs. And we are not confident that the data on the STIs is actually on the IGR. So the point is, on our quality committees, we bring a separate paper which comes through our subcommittee on harms, both Kettering and Northampton. And having said that, in all the medication errors and the moderate severe harms goes through our internal robust governance process. The harms only twice weekly meetings. So we are absolutely aware about what our actual numbers are. Thank you.
Gives out a couple of dollars for that, and I think one of the things we need as a voice to the class is actually, I'm sure we're getting the learning messages. A pretty good draft. So obviously, if the data starts to be debated, then it start actually or a lot more critical on it. So the good example is it's true with case it's complaints. We often full trust this response to complaints. Everything else. We don't ask, was that a good response? How do we know that the complainant was satisfied? Nor, and it may well be the committee, but nor the board. When you say, actually, have we learned the lessons? What have we done about that? How do you know? I never get one. You write some data and everything else, but it seems to me that's not really one of the point. Some of that sort of philosophy, and I know it's a strong philosophy about learning and everything else. Actually, how does the board get sure to remember something like that? And that's the thing. I mean, I think it's really good to report the numbers. But the more important thing to find out, okay, is was every half patients? And what have we done to reduce it? Not less than work, etc. I think that's an assurance, and it's difficult to do. But actually, should that be what it is in your ask? With our complaints, good responses, and then the lesson, etc. Seems to be that. So I guess I know how you do it. And I wasn't feeling possibly very well, but I should do you first.
Thank you. I mean, in response, we do get a very full complaints paper to the quality committee. from both trusts. And we do get examples of learning. I'm not sure though on your point around how satisfied patients are with complaint, whether we've fully fulfilled that. So I think that's a good point and worth taking back.
So we don't know that detail.
No.
Not at least that we are looking at that, and I suppose so.
Thank you. I think that's a good point about learning, and that's the point which is linked to what Jill has mentioned about the NGH executive board being slightly ambivalent about the joint quality committee, because a lot of issues are local and the learning is local, and there are various forums in the system quality meeting for that system learning in place. So the question is whether you need a group committee where local issues like medication errors in Northampton are local and the things which are coming out local. Do you need a committee with 2 hours where it's more reporting and a high level learning rather than having a joint with a committee at hospital level, which can discuss the hospital based issues and embed that learning at a broader level and use the system meetings for the broader quality learning. And that's why I think I would like to explain from our executive point of view at NGH.
So my question was, are the system users effective?
Again, so to be,
We don't have to this is a debate for another day. I take your point, but I think we need to make sure we're wide and learning as well. So I think I know it's not okay. So I think that's all we want. Thank you very much for that. Sorry, we got to some other stuff, but I do think looking forward that seems to be something to all trust on. But the board show how we get ahead and road that I think
Thanks, Jen. So,
Thank you. We met just 4 days before the deadline for the accounts submission. So, of course, the biggest part of the committee was about the letter of representation in our accounts and our reports, something which is super exciting for the accountants, but probably less interesting for people without outside of that profession. What I would like to report to this committee that internal audit has provided us reasonable assurance. However, the direction of travel is not the right one, but with the change of leading partner, I think we've had a good start for this year. Plus, there are more ownership and hands-on from high-end executive team over the internal audit recommendations, not only implementation, but also basically by e-minutes and ownership of them. The point which I would like to draw the board attention to, that in this financial year cycle, the first time the committee is starting to addressing a work around system and processes with regards to clinical audits, because it's within our terms of reference. But in my report, you can see that the level of assurance to be determined. We are still finding the right format of the report and distinguishing the role of quality committee, what they're focusing when they're analyzing results of clinical audit work, and what audit committee is focusing, basically effectiveness and efficiency of the process around planning and around lessons learned. So that's work in progress.
Thank you. Any comments?
I'll continue. So, group finance and performance, Rachel.
Yeah. So over the last 2 months, there's been a number of issues that I'd like to escalate to the board. I'm sure Parliament and Colin will come in on some of these. So in June, the issue to be raised was around the discharge of patients. And we talked about the different processes that KGH and NGH had, which was interesting. And we did express concern that the nursing home capacity was reducing as some change status to residential homes, and that is impacting on our ability to discharge. However, that was probably about May, so we're talking a couple of months ago. In terms of this month's committee, 2 issues to be raised, actually 3, sorry. First is the financial plan and NGH's ability to meet this plan received limited assurance. Now, we've got a session in a private board on this, but actually it's something that we do have to raise, and I'll hand over to Colin in a minute about that. In tandem with that is the efficiencies annual plan and our ability, again, to meet the target that we've been given has been given limited assurance. And again, I'm going to hand over to Becky and Colin on that one. The other difficulty we've got at the moment is, as always, is bed occupancy. Now it looks lower in NGH than KGH, but there are reasons behind that in terms of the number of beds for certain conditions. So, as always, bed occupancy is up. So I'm going to hand over to Colin, if that's all right, just to give a really quick recap on it.
Yeah, sure. Thank you. So there's a finance paper in the pack. As at June, I want to start with an apology that the front cover of that pack actually refers to April, but the rest of the pack is definitely the month 3 position. And as Rachel says, in the escalation and feedback from the performance committee was a group position reference within that feedback, but just to focus from an NGH point of view. And just to update the board on a couple of things that have happened at month 3, the system support funding from the ICB within the ICB contract has been profiled in from month 3 onwards. That was always part of the plan profile. So if anybody was to look at the annual plan figures in the month 3 report compared to early ones, that's actually starting to accelerate because that income's coming in. Also, at month 3 of June, we've had the funding for the agenda for change payable that's been processed in June. That, just to summarise for NGH, that's about an additional £6 million worth of income from our commissioners, and that's been reflected in month 3. At month 3, in terms of the NGH position, the plan year to date was to be a deficit of 4.4 million. That reflects the fact that the efficiency programmes are more weighted towards the latter parts of the year, and actually the position of the 6.4 million deficit, so the 2 million worse than plan. The paper highlights that efficiency shortfall, ongoing pressures in industrial action, and the pay award and other inflation pressures are continuing to cause a problem in the year-to-date position. We've also, as put an adjustment in, or an income assumption in out Q1 for potential loss of elected recovery fund income, because our activity, when measured against those ERF stats, is actually slightly behind plan. It is a complex piece that we're doing some analysis of, because actually at global level, the overall activity position looks quite strong, but actually not all of that activity counts towards that elected recovery target. So we will be expanding the analysis on that in future reports to make that very clear. In terms of the risks, as I mentioned, on a year-to-date basis, the efficiency programme is contributing to the year-to-date deficit, and in the escalation report from the committee, it does talk about a very high-level assessment has been undertaken of where potentially the group as a whole may be heading towards by the end of the year, as some of those risks play out, and if they're not recovered with some of the work that's going on at the moment in terms of further efficiencies being identified. The report quotes a very high-level calculation that's been done, which talks of 50 million for the group. That has been discussed with the ICB as a potential risk figure within our finances. NGH's total within that is 26.6 million, and the main drivers, as I say, for that are current projections around efficiencies, the ongoing industrial action, payables, and some of those particular items. Just to flag within one of a couple of the other parts within the financial position at the moment, we've flagged a risk around capital for the group as a whole in terms of capital as at the end of Q1 was relatively low. In terms of capital spend, this profile to increase as the rest of the year goes through, but it remains a risk of whether we can actually mobilise all of the capital that we were planning to do this financial year. And also cash flows being a bit of a concern in the first part of the year. That's stabilised a bit more now that the existing support funding started to come in. But we are still, for both trusts, keeping a very close eye on the cash profile and just making sure that if we need to request further funding support, that will be processed through the committee in due course. So a little whistle stop tour, but happy to take any questions.
Becky, do you want to add anything on the efficiencies? So I think it's probably worthwhile recognising the great effort of a great number of teams, particularly in our divisions, to identify more schemes than we have had historically in terms of cash out, cost out schemes, which has been a tremendous effort from a lot of people on that respect. It does still leave us with quite a sizable gap to the target that we need to achieve in terms of cost out, and particularly looking at some of the kind of larger cross-cutting schemes around agency and workforce productivity. Is really where we need to get additional focus. But there's, as you sort of said in the report, Rachel, I think there's limited assurance about our ability to fill that gap with those large schemes at this point in the year.
Anything about discharges?
Yes, I think one of the big changes since the previous month is our non-elective position. I think discharges on average in the last 18 months about 390 discharges per month. We're actually achieving over 500 on average every single week as of the 1st of June. So a huge step change in how we're doing business internally, which then driven a lot of discharges. Outcomes of that: patients staying over 21 days dropped from over 180 down to just over 100. The patients staying under 7 days are now over 300. So we're getting a balance of patients going in the right direction, which obviously translates into care and everything following through. We've gone from over 200 patients with no reason to reside, which is a big part of what National's been looking at, down to 150. And so everything's moving in the right direction. A lot of the play out is into ED. Ambulance delays pre-June average of 130 over an hour, which is nothing, which is better than the winter, but still not good enough. June was 103, so far this month we've had 9 in July. So a really big step change in the right direction. But particularly proud of the team in terms of stroke. Normally hitting a stroke thrombolysis bed in 4 hours, we were only hitting 20%. Which isn't good enough. The patient is still getting the thrombolysis, but it was a resus, it wasn't the right place for them. In June, we got better, so we saw 60 patients in June with a stroke, only hit 35%. But in July, we've already seen 80 by halfway through the month, and this report, we hit 65% in 4 hours. And that's a really crucial one, because that's the whole system, that's across Kettering and here, because we do it across Northamptonshire. So really moving in the right direction around that quality. Just a note on cancer, we still remain on the legacy target for March next year. And the RTC, we've hit the no 78 weeklies by the end of July. And that continues to be the case moving forward. Now we've got some extra capacity, and that won't be impacted by the second wave war. Actually getting better on the back of that. So actually, electively, we remain in a very good place. And just to note that whilst we are in the summer, June, July is quite often a peak in terms of attendances. And just for example, June was the fourth busiest month in 15 months, and that's type 1 as well as general attendances. And one of the weeks actually was the second busiest week in 70 weeks. So really, really busy time, and yet we've still managed to reduce our occupancy, our number of delays across the board. And I think that translates into a lot of cost, hopefully, because there is also escalation areas we're not using. So we're not in our respiratory high dependency units, so we're using that for biopsies. So that's we're bringing up consultation forward, less agency goes with it. So really are moving in the right direction. That's where a lot of our spend is on propping up on our elective outlines, etc. So very much.
Thank you. Any questions?
Thank you. Considering that there were, I think, 4 industrial strikes during this year, are there any talks about reducing the threshold for the trusts to be entitled of this elective recovery funds? Are they going to be lowered because of these actions?
Yes, I can take that, and apologies, I meant to mention it in my summary. So NHS England have signalled that as a result of just their assessment of the April strikes, they're looking to reduce the national target by 2%. So at the moment, nationally, organisations are required to deliver 190% of their non-complex activity. Nationally, that's being dropped to 107%. That's what we'll work through in terms of individual trust targets, because they are differential, but our working assumption is that we've assessed that impacts on our potential income loss by about £300,000 to £400,000 per trust for Q1. So about £130,000 to £140,000 per month by dropping that target. What is proposed in terms of treatment is that effectively that element of the ERF fund becomes baseline into the contract. So it's therefore not an item subject to risk. So the amount that we're fighting for, if you like, is actually reduced, or there's more secured income in the base contract. NHS England have said that as the impact of subsequent industrial action is identified, they will again review those targets. The other things that they are looking at nationally is the impact of the agenda change paywall, because most organisations are flagging a pressure that's coming from that, and also ongoing non-pay utilities and other inflation pressures that are higher than the planning assumptions that were distributed when plans were set. We have also done a return recently to NHS England for what we assess as the impact of industrial action for Q1. We've submitted that in both of the pay cost impacts in terms of, for example, junior doctors reductions and consultant support, etc. We've also been asked to estimate the activity impact that's come through from being impacted on by the industrial action. The limitation in what we've responded is that we can only at the moment directly report those actual positive cancellations. So the appointments and procedures that just weren't booked because we knew there was industrial action sometime in the future, that's not actually been captured at the moment. So we've heavily caveated our response to say this is the impact we can absolutely measure and catch. But there is further work to be done to say, for example, what is the activity in a non-strike week compared to a strike week, to say, well, actually, there's clearly a level of proactively not booked activity that we're losing as a result of that industrial action. If that's not too many double negatives.
Can I just a couple of things from you? When I think you said for the 2 trusts, potential of 26 million years.
50 for the 2 trusts combined, 26.6 for NGH.
50, is that?
Yeah. As I say, that is very much
red 50 has been that.
The ICB are working on their own forecast and NHFT as well, so that we can produce a line position.
But actually, if we're not there, we would be in a very place. I've also said, I suspect special measures, etc. Because for the 2 trusts at 50, that is really double the absolute score of the NHS. That's more than double it. So that's the sort of comparative with it. So all trusts are struggling, but the numbers here are huge compared to the size. So I suppose my question is, what we want to focus on is, we know to save money with issues of staffing, these issues are, can we do all the things we said we wanted to do? So do you think there's enough focus on that? Because getting to the end of the year with 50 million will not be less. As I said before, that actually really good performance in operational performance, etc. buys with some magnitude, some time in financial frame. Doesn't buy you £50 million. And I just think question is, all we have to say is, how, whatever number we get, how will we sit down with the regulators at the end of the year? Are we going to demonstrate that we have done everything possible? Consider it's a really difficult decision. And, you know, that was, and then we've got to this number for the years, and we have to convince them. And it's going to be quite hard to convince them to put too many across the two trusts and done that. So I suppose the question across the board is, what else do we need to make sure that we're absolutely top of that? And how robust is going to is the 50 million forecast? Because, you know, if that robust, if that was, as well as I don't have the discussion now. I do think that maybe we put that in private, but actually I think we need to be really challenged ourselves about that. We've got some really good stuff, but we're 50 million euros as opposed to trusts. That would be a ridiculous. I think we need to do everything we can to avoid that, and we need to be getting that one done. We need to be able to demonstrate the good time of the story. And maybe I'm being unfair, I can hear that wrong, but it seems to me there's a main question that Chair wants.
In all honesty, I don't think it's a naive question, and I think it's something that we've got a session on it in private board, and I think it's going to be a good session, and we need to be really honest about what to do. Thank you.
Okay. Yeah, I think I know this. I was thinking, do you also need to recognise these issues? Absolutely. Discussion.
No, completely agree.
I think it's actually right. You can discussion fine, but yeah, because we celebrate our successes, we need to recognise our challenges. Thank you.
Okay, group people, please.
Yes, thank you. So I obviously take the overview reports as read. The things that I'd like to pull out of that and flag up with the board. Overall, obviously, we're all aware that there are issues in terms of people and workforce side of things. There's also a massive amount of work going on, and I think in some areas we are starting to see the benefits of that. So, in overarching terms, looking at the June-July picture. There has been an increase in vacancy numbers. However, at NGH, the time to hire has really improved over the last few months. There's been a real focus on that, which was very definitely needed, and that's starting to pay dividends. Also on the positive side of things, the mandatory training, again, there's been a huge improvement on that, a real focus. We were well below target there, and we're around target, and appraisal rates are improving, so we're not always where we need to be. I think the aspects that I really need to highlight for the board. Firstly, and I promise this wasn't definitely my first point even before you spoke, Chair, it's about agency spend. This does receive a huge amount of focus. Those execs who are at people committee will, I'm sure, back that up each month. I still feel that we are at the point where we're still getting right underneath the figures. I know that there is a huge amount of work, and I am assured in terms of the focus that is given by the execs and by the people team on this, and processes have been put in place over the last couple of months. I think that what we have asked for is additional workforce information to understand what sits underneath some of the figures in terms of, certainly in June, we saw an increase in agency and a decrease in bank. And obviously the bank side of things is less costly than agency. So we really need to see that shift move. And so as a committee, we've asked for further information on why is that the case, and are there any barriers to our staff doing bank work that could replace the more expensive agency side of things. So that is a small bit of work, but one that is definitely targeted at decreasing the agency spend. We were also, we had the Tackling Racism report. We have made a recommendation that this report, not necessarily the report in full, but some of the EDI and workforce plans come to a board development at a future stage. Tackling racism is something that has been a theme in all of our staff surveys, certainly since I've been here, so the last 3 staff surveys, and it's very clear that tackling racism starts at the top. It starts with us as a board. So there are some really good pieces of work that are taking place, and we do want to bring that to the board as part of a board development session at some stage. We were able to give substantial assurance to the medical appraisal and revalidation report at the moment, and we did also make the point that we felt that we gave it substantial assurance. We felt very assured this year. It was a good report. There's a lot of work going on around the job planning side of things that gave us more assurance even than we've had before. So that was really a very positive action. Also on the positive side of things, volunteering, I just wanted to bring that to the board just again as a recognition. It was a great report, and we did acknowledge that without the volunteers that we have here, we're not quite sure how the hospital would run. So it's a group of people that we're highly dependent on, and they do a lot of really great work. Finally, on the employee relations side of things, there's been work going on the employee relations side of things to ensure that as a committee, we are assured that we are doing everything that we can in terms of both education of managers and also the management of employee relations cases. Again, there's been a lot of work going on that in the last 12 months. I think it's fair to say 12 months ago we were not where we needed to be. Very much more assured now, and that's really important, that a lot of the work that's going on there is around education of managers and tackling the root causes of some of these employee relations cases. I think the only other thing to note is that unfortunately we were unable to form assurance in terms of the staffing report. We had no representation from NGH. We did have a few issues because of the strike on the day of the people committee, but we did make the observation that we do continually work above the drill limits. So that is definitely something that we need to be focused on.
Thank you, Chair. Could I just ask a bit more about the bank, because I know more about maternity services in detail than I do other areas in trust, but at the moment, unfortunately, we have a 40 to 50% felt vacancy in maternity services, so we heavily rely on the bank. And our bank pays differently to Kettering's bank, and there's also an incentive in many ways for staff to leave and go on to the bank, because they can actually be very flexible in the way in which they work, and they can actually get paid more. So we are eagerly anticipating the collaborative bank beginning, so that we can have the same pay rates and we don't have staff going from one trust to the other. And I just wondered what the timescale was and whether we could really push on that.
So we discussed that finance and performance, and completely agree it needs resolving. Apparently it's been a big conversation, it's been going on for a year. However, we were made aware that a letter had been received from the ICB that most of us haven't seen, so we paused that decision. We're going to make that decision very quickly. The proposal is that we pay the same across all 3 hospitals, so less of the we just have some discussion with
Okay. Well, and then I will put Paula in if that's okay, Chair, as well. The bank that Rachel's referring to is Medical Bank, the Medical Bank rates. One of the issues that we have in terms of the wider bank is, you're right, there are differentials between the bank rates. However, because of the bonus that we pay at NGH, at the moment we pay more at NGH than KGH. And if that's taken away, in order to make sure that everyone gets the same bank rates, there's clearly a big implication there, which might not necessarily move us in the direction we want to be going. So there has been delay, but there are a lot of quite complicated discussions going on behind the scenes to make sure that the whole purpose that's behind collaborative banking is going to be achieved by bringing it in. It's not going to make a situation worse.
So, thank you, Denise. So the decision was taken some time ago to remove the next bank bonus. So it was introduced a number of years ago as an incentive to increase bank fill rates. And clearly, when you had an incentive in for a very prolonged period of time, it's no longer an incentive for these. It's part and parcel of routine pay. And so NGH took a decision a while ago to remove it. But then, of course, we've had the financial crisis, real concern over the impact on our staff, which is unrest, that's completely understandably. And Maria and I have spoken recently, and Maria and her senior nursing colleagues are still of the view that the nurse bank bonus isn't doing any more than we wanted to do in terms of driving the fill. But actually to take it out without a replacement arrangement would not be the right thing to do. So Maria and colleagues at Kettering are currently in discussions around how we use the escalated rates that we've already agreed across the group, which are consistent, and how we switch those on and switch those off and use those instead as a motivator to increase and drive fill rates. And once we've agreed that, the process in principle, then we will give notice to our staff to change the current arrangement for this new arrangement. So it is very much on the agenda, Jill, and it's a high priority that Graham is currently working on, with a view to, because we need to do that, you're quite right, to facilitate the collaborative bank.
Thank you. Is your time scale?
I know it's been discussed at HMT very recently, and Maria and Tracy and colleagues at Kettering are looking at the alternative plan now, with a view to bringing it, so engaging it during August to bring it back and hopefully for decisions.
So last point to add is in Maria's absence, there is a East Midlands midwifery communications which is going on. So we initiated last month on the midwifery point of view to standardize across the patch. I'm sure many will bring an update to the board on that, but there are already discussions going on across the patch.
So I mean, I think those presumably come back to the issue about speeding this. We talked about the working in that society. Have we looked at any other trusts, other mentions? All the help of the local news agency staff about 3 years. We've done something different. I think we're not thinking of the areas of businesses. That's lie. And I think we're just we might try and find others trust that we're better. I can't imagine that we're out to this capability or its local geography. So maybe instead of getting those we should be looking at that. But I think there's maybe some other trusts and stuff like that. But I'm sure this will come back. But there is a need given the financial position to try and do something that's as quickly as we can.
Yeah.
I mean, if I can move us on that, if I can, because well, that's part of the training is obviously a bit flat. So the final one.
So group transformation, Jill.
Thank you. So I'm normally the co-chair of the Transformation Committee, and this was the first group digital hospital committee I attended. So I'll need to rely on Natasha and Becky to support me. The Digital Committee and the Transformation Committee joined together for the first time, and so you will see the items that we discussed in the board paper. And just to support the discussion that we had earlier, the one limited assurance we had was around the IGL, because we continue to not make the progress we would like in that development. We've already covered that. It's now urgent and outstanding. Other than that, I think I'll leave people to read the paper and ask any questions.
political observations?
I'll just come in on the ICB update because conscious that it's also been in the national media around the results of the digital maturity assessment. And just to provide some context, we did talk about that at the Groups Hospital Committee. The results, albeit disappointing, aren't a surprise, particularly given that we have in NGH, we don't have an EPR solution yet. And also we have got some critical projects on the horizon which will support the uplift of that score, both at organisational level and at ICS, such as the Northamptonshire Shared Care Record. We'll continue to monitor and track our progress against that assessment at ICS level, of which we are part of those conversations. So just wanted that aired, as I'm really conscious that it's obviously being talked about in the media too.
I think we would have to I think we need to take it seriously, but yeah, it's become an element of subjectivity. I personally am much more interested in what the solutions to communities. Because that's the most key to hear, because actually that's what's going to improve patient care. That's what's going to help free up some time and take people decisions. So while we need to look at that, so I'm particularly interested in the solutions to that we can use to show them. Okay. Thank you again. Thank you. Okay, we've got a break. I'm going to suggest that we stop for 10 minutes. That's all this book's going to be charged. Can I request that we've got two items, both of them are for we'll come to this. I see Jonathan is there as well. Let's just try and make those 15 minutes and the two pieces of work of papers that has been done on the presentation to these items and discussion of that. I think the last two items probably don't require much discussion. So we hope it comes as near as 12. I know the visits are all that really important, and also the stocks quite. That's three those two do that. So we might get over a bit, but if we can try and do that, that would be great. Okay, 10 minutes then we come so away. So can we do that by just from our past to the line? Thank you. I can get the charities today, it's sort of, since they've got a while on. I think it's probably still needs to do the work, see if we can. Is that all right, John?
Apologies, I'm struggling to hear what you're saying down that end.
Sorry, I'm mumbling again. I was going to ask you to come forward and do your presentation.
Yes,
Your
certainly.
and then we'll do the moderation later. Is that okay?
Yeah, that's fine. Thank you. Thank you. I believe Richard is going to share it now.
Yeah, yeah. See that, Jonathan?
I can. Perfect. Thank you.
Right.
Okay, so I'll rush through this because I know you're short of time. Good morning, everyone. My name is Jonathan McGee, and I'm the new Chief Executive of Northamptonshire Health Charity, and I took over about 4 weeks ago from Keith Brooks. I'm just going to run through a few slides to show you what your charity has achieved over the last financial year and some of what we want to do for the future. Next slide, please. So I'm pleased to say that we spent over 1.3 million across the trusts last year to help patients and staff. Our ambition is, of course, to raise more money in the future. I'm hoping we can look at doubling that in due course, and therefore spending more as well. So I'm going to run through a few examples of what the charity has funded over the last year. Next slide, please. So first is to show you the refurbishment of the new critical care unit, where the charity has been able to enhance the space above and beyond that which would normally be funded, and we've been able to enhance that space with information graphics, murals, LED skylights and comfortable furniture to make things just a little bit better for patients and their families. So improving patient spaces is a really key thing to alleviating anxiety for people when they are staying in hospital. Next slide, please. And that extends to like the Swan rooms that the charity has been able to support as well. These allow people to spend time in hospital with a dying loved one, and the charities help fund comfortable bed, chairs, drink making facilities, etc. And those donations have allowed us to demonstrate the effectiveness of those rooms, and the trust has therefore enabled funding for further rooms, Swan rooms across hospital. And recently we had the family of Hannah Payne come in to open the new family Swan room up. Their fundraising helps fund that, and that gives relatives or caregivers who don't live local to NGH a quiet space with kitchen and washroom facilities and a room next door where they can stay if they're visiting their loved ones, but they can still remain on site, which alleviates just a small part of the anxiety. Next slide, please. And we're also pleased to announce that with the near completion of the Gossip parent rooms, these are just waiting for furniture to go in, but again, these allow parents to stay with their ill newborns and saves parents long commutes or having to arrange hotels, etc. So providing that home for home within the hospital, home from home within hospital even. Next slide, please. And it's not just environments that the charity supports. We look at supporting equipment and technologies over and above that funded by the NHS, but that will help patients. So some of the things we funded last year include light therapy that reduces inflammation, scalp cooling machines to help patients retain their hair during chemotherapy treatment, and online systems that help patients who do not have English as their first language, so they can understand what procedures are being done or what's going to happen to them. Next slide, please. But it's not just patients the charity supports. The NHS would be nothing without its staff. And over the last year, the charity has supported the funding of the house-based wellbeing hub for staff and refurbished the Eat Street restaurant, so staff have a more pleasant place to eat. I'll come on to it in a minute, but we're looking at increasing how we can support staff across the trust. I think that's a key thing that the charity can do, and it's over the COVID period we've seen that support for staff, just as the communities have reached out and they're willing to support that, and they continue to support that. Next slide, please. So some of the small things we can do to help staff wellbeing, such as supporting the Staff Excellence Awards. I hear they went down well. Obviously, I wasn't there for them, but yeah, that's just another small thing that the charity can help fund and support to make things a bit better for staff and celebrate them. Next slide, please. And that includes supporting staff for continual training and development, such as funding the nursing and midwifery conferences, and the Nurse Day celebrations, including restoration days for staff, which helps them decompress and discuss and chat and improve well-being. So we're going to continue supporting staff through the charity, and I think it's important for us because that helps benefit patients as well, and we've launched a £75,000 campaign to raise £75,000 to improve staff rooms across the trust, so staff have a more pleasant, relaxing environment to have breaks in shifts, etc. afterwards, or just decompress. So it's a real key focus of ours for the next few years. Next slide, please. These awards that the charity's received, they're included here not to gloat about the charity, but actually to show that there's recognition out there in the community about what the charity can do for the hospital. It's all about patients and staff. This is just recognition that people want to support the trusts and help patients and staff. So that's why I'm including that there. It's not about the charity. We just facilitate donations getting towards where they're needed. Next slide, please. So over the next year or so, we're going to continue looking at improving patient care and staff wellbeing across the trust. And we will hopefully be completing a few of our appeals this financial year, including, for example, the Daisy Suite appeal. We're hopefully going to close those off and get the implementation plans in within our charitable financial year. The other key thing to note about the charities, it's not just the community that can help fundraise money that can be spent on patient benefit and staff wellbeing. Staff can take part as well. So I'd encourage people to speak to staff and say, you know, you can fundraise as well for the charity and support the hospital. One thing that we're going to be focusing on in future is to try and increase our general funds for the trusts. Having unrestricted general funds means we can do more across the trust. So rather than each ward or department having 100% of a small pot of money, by having larger general funds, they can apply to those and do more transformational things. And at the moment, lots of departments will miss out on the larger donations just because of where they're situated. Not all areas on a patient pathway will receive the same amount of funding, so we want to make it more equitable. For example, we'd like to refurbish the mortuary visiting area, but they don't receive a lot of money. So our general our move towards more general unrestricted funds is so that we can be more strategic, do things across the trust and have greater impact. So yeah, essentially we're going to be reflecting on our and reviewing and refreshing our strategy over next year, so we can make it easier for patients, their friends and families to donate, make it better for staff within the trust, and importantly, make it easier to spend money where the need is greatest. So if anyone's got any questions or wants to support the charity or anything indeed, please do get in touch. Thank you.
Thank you very much. And before I open it up, I'd like to say thank you for the work you do, the support you do to staff and patients. I think it's really valued, I know, in the trust, and I think it does take a lot of time, a lot of effort. So I just like to pass on formally all thanks, pass on to the team and
thank you,
etc. It'd be great because we don't show enough appreciation. And I think this is appreciation. Sure.
Thank you, Chair. I was going to say something along similar lines, so thank you. We had a meeting about 3 weeks ago, I think, Jonathan, where we said goodbye to Keith Brooks, who'd done an enormous amount of work, and we thanked him and had a celebration of the time and effort that he gave to us. And would want to welcome Jonathan, who brings a wealth of experience from Adam Brooks in relation to charity fundraising. So we look forward to the future and doing even more in an incredibly difficult context, because we're having fewer legacies now than we've had in the past, and fundraising is quite difficult given the economic climate. So things get harder, Jonathan, rather than easier, don't they?
Yeah, they do, but I like a challenge. But yeah, yes, I was at 5 years at Adam Brooks Charitable Trust, and there's money out there if you know where to look. But it's not easy. It is hard. We will do our best and keep raising that money and hopefully transforming the trust where we can.
I'd just like to thank you on behalf of our staff, Jonathan. We have spent time this morning talking about the financial challenge that we're facing. We have never needed our staff more than we do now, to retain high quality staff, to develop their staff and to keep them, and to allow them to do their best. And some of the things that you do makes staff experience better. And we thank you very much for the work that you're doing to support that. I bumped into someone this morning who's heavily involved with the new our space area that you helped fund, and it's been really well used, and particularly at night when staff are going there to use that space. So thank you for what you do for our staff and for that, which is a very practical facility that you've been able to open to staff recently.
Thank you. I'll pass on the message.
Thank you, John. Incredible work. It's really amazing to see how much charity can do with such a huge impact for our patients and staff. Do we do anything, or do we receive anything from NHS Together? I think there is a joint NHS charity.
Yes,
do we get any grants from them?
Yes, we have had the last grant from them. So that went towards some of these staff areas and improvements. I can't give you the detail. I'm still catching up on lots of paperwork. But yes, we have had our grants from NHS Charities Together. However, I'm going to a meeting with NHS Charities Together in September, and they will be discussing what their next rounds of grants might look like and where they might be directed. So at the moment, I don't know. There's nothing we can apply for at the moment. Those grants have been all given out and closed, but they will be discussing what their proposed next round of grants are. So yes, we do apply for them. And Keith, until recently, he stepped down. He was their treasurer, so we're quite well connected into that.
Thank you.
Okay, well, thank you very much, Jonathan. And I'll try and find some. I will find some time to catch up with you. Right.
That'd be fantastic. Thank you.
Just find out a little more about what you're up to. Okay.
Fantastic.
Thank you very much. Thanks.
Thank you. I'll leave you all to it. Thank you. Bye bye.
Okay.
Thank you. Okay, so previously we've spent quite a long time in these meetings and board development sessions talking about the culture that we want to achieve in our organisations, and how important it is to make sure that everybody feels included and able to give their best and achieve their best while they work for us. And our strategic aim is to be an inclusive place to work where everyone is empowered to make a difference. We've spent time with Michael West, hearing about the importance of a compassionate and inclusive culture and the direct impact that has on patient experience, patient care, and reduced staff turnover. And there's an increasing body of evidence that talks about the need to make sure that we do have a truly inclusive culture. So Dawson's research talks about the perception of unfair treatment and discrimination really impacting directly upon patient satisfaction. So there's a huge body of evidence around making sure that all of our staff feel included and can contribute fully in the workplace and have a really positive experience. But we know from our own staff survey results that we have feedback from our REACH colleagues in particular, that a third of them have experienced bullying, harassment, discrimination from their colleagues. And we know that they tell us that their perceptions of fairness are that the opportunities here are not as favourable as for white colleagues, and that they are more likely to experience discrimination than their white colleagues. So we've identified this as a problem, something that we want to focus on. And we've had discussions about this at Board Development where we'll talk through this in some detail. So the People Committee looked in detail at the plan and bringing it here for approval at the board. 3 areas of focus in the plan. Firstly, to set very clear standards of the behaviour that we seek and expect in our organisations, and a commitment that where we don't meet those standards, that we will tell the organisation what we've done about it and how we have addressed behaviour that doesn't meet standards that we expect. That we will focus on education, educating ourselves, educating our leaders, educating colleagues to improve our cultural competence across all levels of the organisation, and that we will co-design, particularly with our networks, the approach that we will take, and we will do this with a bottom-up and top-down approach. So clearly board endorsement of this is absolutely critical, but we also need to hear from colleagues at the ground in terms of what will make a difference to them and get them involved in designing the approaches that we will take. The paper outlines 5 areas of focus, so executive leadership, so for example each of us having an EDI objective within our personal objectives for the year, HR processes and capabilities, so for example focusing on the role of our cultural ambassadors that we have in each organisation and how they can help us to develop cultural competence on the shop floor. In terms of cultural competence, particularly focused on an education programme for middle managers upwards. Making sure that we're able to recruit and develop talent. Over recent years, we've recruited a lot of colleagues internationally. We now have a significant number of internationally educated colleagues at Band 5. We need to make sure we're able to develop that talent and see those people progress through into more senior roles in our organisation and retain those skills and talent. So the Levelling Up programme that started in NGH and has now been moved across to KGH is an excellent example of how we're supporting our internationally educated nurses. And finally, we need to provide additional support for our REACH staff through, in particular, the networks. Colleagues who sit on networks, lead networks, have other roles and don't always necessarily have the skills to lead a network. So it's really important that we provide them with support and capabilities and capacity to ensure those networks thrive and can help us to achieve our goals. We've already got quite a lot of work underway. The paper outlines some of the early things that we are doing. We've agreed in terms of governance that we will have working groups at each hospital so that we get the local nuance and local priorities fed through. And then we will have a steering group that sits across the hospitals to ensure that we can monitor and measure our progress and share learning and share our findings as we develop and evolve. So I'm asking the board today to confirm their support and commitment to improving inclusion, specifically by tackling racism in our organisations and giving their approval to the plan.
Thanks, John. 2 points, 2 questions. Firstly, a big thank you to yourself, Paula, and all of the team leading on this piece of work. And I think it's something that we have vocally supported before, but just to say on record, completely support the plan. My second point was, and I'm going into a bit of the detail, but within the plan itself, it'd be great, some of the success metrics I'd suggest are outputs, the thing we're trying to do, it'd be great to have the so what, so the outcome that we're going to drive on the back of it, so we can say actually that intervention's been successful. And then 2 questions. One is there any learning from elsewhere of the trusts that we could incorporate, or other organisations, I should say, that we may have already put into this thinking within the plan, or we may continue to do. And then the second one around governance. So great that we're having a steering committee, just so we can have assurance about where we will hear about the progress. Is the view that this will link in with the people committee going forward, and then up from there. Do you want to take all the questions?
Yeah, we'll take that. Bill?
Completely support the paper, but a couple of questions, and one of mine was going to be metrics, Natasha, so thank you. I wonder how non-executive directors can support you in this work. I don't think I saw a mention of it in the paper, and I know some of us do support the networks. And on that note, I wonder, is there any thought about reviewing the number of network meetings? So the one I attend, unfortunately, because of pressure of work, the board sponsor is unable to attend. I think that happens in a number of meetings because there's so many of them. And we haven't got enough non-executive directors to cover all of them. So I just wondered if there was any thought about reviewing the networks and whether any of them would be aligned, because that would be easier to support than the number of groups we've got at the moment.
So yes, in terms of outcomes, within our 15 KPIs, 2 of the KPIs are directly linked to this, which are in terms of the measures around discrimination and harassment that colleagues report. So up until now, we've had that measure annually as a staff survey. We've now included it in the people pulse, so we'll get a quarterly measure that will come through and enable us to track that. In terms of some of the other features, you're right, we need to be very specific in terms of what will be different and how will we see that. In terms of reporting, that will come to the people committee through the twice annually strategy sessions. So that's all we report. And we'll report in the wider context of our culture work. So the work that Debbie and Heidi are leading in the organisation around cultural change and reporting from that wider context. Yes, there's a significant amount of learning from elsewhere. There are a number of bodies that we are part of, so ENEI, you asked what that stands for, employers, something for equality and inclusion. We benchmark against them and use a lot of their resources. There's also, we're very networked through Tracy's leadership with regional colleagues who lead this work, and there's a very strong leadership actually from the region who we see in this piece of work. So a lot of that learning has been built by Matt into the plan, but it's always necessary to keep looking outside. And again, through the system, through Diana Belfort, we have a really strong leader in engineering this space who we benefit from. Matt has led a review of the network still. There's a piece of analysis being done recently that I know Tracy's brought through to H&T very recently, looking at the strengths of the networks, where they strengthen, what could improve and make things better. You're right, executive leadership is essentially a challenge. And I think we need to follow the actions that have been identified with what the networks have told us in terms of how we can strengthen their presence.
Non-executive directors, that part of the review.
Yes, non-executive directors, of course, are always welcome and play a very, very valuable role in that sort of critical friend of them. So I will be very keen to see non-execs involved in that work.
On the point which Jill has mentioned, putting my clinical and a BAME hat, I think we need to be have a balanced view about networks, because inclusivity is about not putting people into boxes and ensuring there is a balance of empowering people, but not at the same time disempowering certain sections. So I would welcome and obviously we put a robust support around IMG. I think we need to have a comprehensive inclusive plan for the entire organization, rather than having a focused saga of people into networks. Just want to make that part. Thank you.
So a couple of points. One, I noticed the all board members have specific and measurable EDI objectives. The target date is October 2024, and that feels like a long way away. So I just wondered whether or not we could perhaps challenge ourselves to bring that forward, given it's.
Sorry, can I, yeah, I come in there. One of the next steps from the people committee that was reported is that we have asked for several of the measures and the dates to be revisited, and they will be revisited.
And the second point, I think, you know, looking at some of the results from the people pulse question around have you experienced discrimination in the last 12 months, I do think it would be helpful to also ask the positive balancer of that. Have you experienced your manager or a team member displaying inclusive activity? I don't know quite what the right word would be. So that we're able to identify, you know, what are those inclusive practices that people are doing that are really genuinely valued by the staff, recognising, as Helen said, there's a lot of people who aren't part of the network. And I do think it creates a more balanced conversation.
I think that will also provide useful information in terms of where we've got pockets of excellence, and we can help spread that good practice.
It's just to say that I have asked all to have those objectives already, so we have been submitting to the objectives to make sure we're on, and we still have to start on first mentoring as well from the system, so not just really know what I do in my NHT. So it really is a step forward in actually the system wide. It's not just NGH.
Okay, I'll just have a few points. I think it's really good work. I think points. Just I think it's really important. That's important you know that. That's what I have to start with. I need to do that in a role which is sensitive but also sincere. And second, I know there are all sorts of drivers in this, especially rules everywhere. There's a moral responsibility. It's not, we shouldn't be driven by what National saying. We should be driven by that moral responsibility that we have. And there are some things that we need to give people permission to call them out. I have 2 legs that we actually, they can call them out, including public in all main comments. And most of the board look like me have at some stage in the last 2 years been called out. Not because they've done anything wrong in the last week, they just sometimes say things or do things, or we don't respond when it is important. We have that, so I think it is that. The other point I think is that we also need to be thinking about communities, patients. This I know as a staff, but actually we know that changing the way we can all care. We know that engaging with communities make a real difference to effective access to this development. And that's not just for that. We know there are equitable outcomes to really some services. I know that's a good start, and I do think we need to think about that. We need to look at ourselves. We're all the same parts of actually, sorry. Oh, sorry, the rare. So we've got to, but actually, that's the one. So, you know, doing these things we look at future approaches to how we have that's something all trusts go with. But there are things we can do. Further quickly, some trusts have appointed associates who then hopefully will move to a full notified soon, but yeah, it gives people experience and that sort of thing. So I think we need to think about that. I'm a little bit worried about the governance. We need to be very careful. We don't make the industry. This is about the evidence and people. So can I just ask you just be careful that we have a streamlined and get these back measures, but just on the conversations and the podcast, just being the way it is top of the study. And finally, a suggestion we might suggest that any business case, any proposal has an impact assessment on inclusivity and diversity that comes with this. So we're actually looking at everything from that perspective. So those are just my observations of something I've had this discussion with other boards and everyone's trying to address this. So those are the observations. If you just reflect, I do think this is really important, and there's a good line more to it. Yeah. Okay. Okay, we've got 3 more items we're catching up. First of all, governance review.
Yeah, it'll only take a few minutes, hopefully. So this is around the committees in common. They started off nearly 3 years ago, having committees in common. That's ebbed and flowed over the years, over the last couple of years. And then last year they stopped, just to make sure that we had something that was fit for purpose. Or finance has stopped, and so has quality. So those two, there were concerns expressed. Thoughts of the committees and the ability to actually review what we needed to. So they started again as committees in common in January. And since then, they've been reviewed a couple of times. And I absolutely note the differing opinions of non-execs with whether we should continue with them or not. Some are very much for, some have concerns. I absolutely accept that and note that. Right now, we're in a place where certainly finance is working well. I think there is more of a division amongst attendees in quality as to how well it's working. You can come in, Jill. And we're at the point where I think we've had a review, and the review says that we should continue. However, there is an understanding with John's arrival that there will be a more formal review of committees in common, and I absolutely accept that. Jill, do you want to say anything about quality?
If I may, thank you for the introduction. So just a few words. I mean, we touched on this earlier, and I meant to set out the view of the NGH execs. I think although Palmer can come as well, obviously. But the 5 non-execs that sit on the committee, 3 from KGH and 2 from NGH, would like me to just say a few words, if I may. It's an important committee. If Andre was here, he would be saying it, so he's in full support. So why we think, as the 5 non-executive directors, think that the committee should continue, is that you've seen a list of macro learning in the paper, which has been very useful for us across the 2 organisations. But every month there's micro learning. And I spoke about the anti-embolism stockings earlier, an issue at KGH which they're looking into. So that's aroused our concerns to have a look at it in NGH. So there's a lot of micro things that we share. Ward visiting, for example, KGH have got a good system which we can work together and learn from. The 5 of us have got all different skills, and so we think we bring quite a lot to the party by being 5 of us, so that we can, between us, constructively challenge and discuss the issues before us. It's the only place where the current 3 collaborative priorities are reviewed and overseen from a quality perspective. So if we have 2 separate committees, that would be then disjointed in terms of the discussion. A concern that if the single committee, if the committee was disbanded, this might signal the end of joint working to the clinicians. So that was a message that they wanted to give. And finally, we have learning events when we had single committees across the 2 trusts, but they weren't well attended in many of the instances, and quite often cancelled due to pressure of work because they're not mandatory. So I just wanted to share with you the views of the non-execs. But we absolutely welcome the governance review and will obviously respect any decision that's made in relation to that.
Thank you. I also support the independent governance review because it would really be very, very helpful in the current situation. I would like to clarify one point in the paper which is here. In the paragraph 5, it says that internal audit conducted a review. It was advisory review. So it's unusual for advisory review to give an assurance level. And this paper hasn't been at the audit committee, so I cannot comment on the substance and say why it's such an unusual situation when it's advisory review, but with a reasonable assurance attached to it. So maybe that point has to be clarified. I think Richard wants to come on it, but 2 points for the coming governance review. It would be really good to find, with the help of the external expertise, and to find the right balance of negative assurance and positive assurances, because at the current stage we really rely a lot on the negative assurances, and that is I would say it's a little bit weaker to the system I got used to working.
That's very helpful. Thank you.
Oh yeah, very briefly. Sorry, just to clarify, and apologies, the report could have been clearer. The assurance level is from the Finance and Quality Committee rather than the Audit Committee, and it's a matter of timing, just in terms of this meeting and the next Audit Committee. That final report will all be going to the next Audit Committees in September. Thank you.
I think the conclusion is
Absolutely.
Well, you continue to join committees.
There is something. There's something additional. I absolutely agree. There's something additional I just need to cover, which is the non-exec establishment. So there are 6 roles, 6 voting non-execs in NGH. Annette, for personal reasons, has stepped aside and has agreed to take an associate role. So we do have a vacancy. Now, in the board papers, we talk about offering the voting role to Andre. Absolutely understand. People have said to me they are slightly concerned about his time, and I understand that. Recently, he's taken on another role, so I think he is going to be overstretched if we offer him the voting role. So I will talk to him about what he wants to do. But actually, I think we have advertised for 2 associate roles, and we will carry on with that process and look for appointments. Sorry? Oh.
Sorry, John, there was also a recommendation just around the safeguarding the role re-positions report today. Do you want to leave that?
We need to leave that until we appointed non-exec.
All right, so
Jill is taking that role on temporarily.
Okay, thank you. Remuneration appointments committee terms of reference.
So up until now, we have had 2 separate remuneration committees with separate names and separate terms of reference in each organisation. They meet separately and occasionally meet together with considerations that are for group laws in particular. This proposal today is to align the terms of reference for both committees. KGH to change their name so that we have a consistent naming convention for both committees. They will still meet separately as and when required, but also when they're meeting together, they then have aligned terms of reference.
You have thanks. We don't have any questions to the public understanding, and we have already raised the award of the honorary doctor of laws to make more apprentices formally as somebody any other business goes out. That's calculations. Okay, thank you. That brings us to the end of the public meeting. Thank you very much. Thank you. Yes, please.
I'll just wait till the live event finishes.